Hello there, my name's Yuko Smith. I'm a consultant urological surgeon at the Queen Elizabeth Hospital in Birmingham. And my remit's talking about minimally invasive PCNL, achieving the best outcomes. As you know, the EAU guidelines for urolithiasis recommend PCNL as a preferred option for stones of over 20 millimetres. And they also recommend endourological management with either URS or PCNL for lower pole stones of greater than 1 centimetre. So what's the definition of a mini PCNL? Standard PCNL with a sheath of 22 to 30 French has previously been considered to be the gold standard treatment for large intrarenal stones. The large access gives excellent visibility and the ability to break and remove large fragments of stone. The larger sheath, however, brings the disadvantages of greater blood loss. Mini PCNL sheath sizes of 14 to 20 French have now become the mainstay for managing intrarenal stones of around 2 centimetres due to the perception of reduced invasiveness, but there may be questions about whether the outcomes are equivalent. Ultra mini or micro PCNL with an access of less than 13 French will give increased manoeuvrability around narrow collecting systems. However, particularly with sort of suction access catheters with flexible ureteroscopy, there may be a question about how much a micro PCNL might add. So the question is switching down to a mini a trade-off between reduced invasiveness and outcomes? So how do we define outcomes in PCNL? Obviously, the stone-free rate is critical for our patients, and this will depend to some degree on the imaging modality used for follow-up. Time, so operative time. In the days of long waiting lists, our managers are keen for us to do each operation quickly and do more operations. And even from a patient point of view, there's a suggestion that keeping your operative time to less than 2 hours may reduce your complication rate. Post-operative fever and sepsis and other complications are clearly important to our patients. And blood loss is of key importance to our patients, both in terms of transfusion and angioembolization risk. Managers are obviously very concerned about length of stay. And from our patient's point of view, post-operative discomfort will be important. In the cash-strapped NHS, there may also be concerns about the cost of the procedure, which will be a balance between the costs of consumables, but probably more importantly, the operating theatre resources. So in comparing mini PCNL with standard PCNL, multiple systematic and meta-analyses have shown no significant difference in overall stone-free rate between mini and standard PCNL. However, standard PCNL had a shorter operating time in comparison to mini PCNL, and the length of stay was usually shorter with a mini PCNL. Post-operative urine leakage, blood loss transfusion was higher in the standard PCNL group, especially where the sheath is 30 French. Fever and embolization was not statistically different. We've all become increasingly aware of the importance of intrarenal pressure on post-operative outcomes. Compared to standard PCNL, where mean intrarenal pressures were less than 20 centimetres of water in this top study, animal models showed much higher intrarenal pressures in the mini PCNL models, and over 50 centimetres of water was observed. And we have become aware that pressures of 30 to 40 centimetres of water may produce pilovenous backflow, and with this, greater post-operative discomfort and infection rates. The bottom study was a porcine model where uropathogens were instilled into the renal pelvis during PCNL, and either a mini or a standard PCNL was subsequently performed. And in this study, they showed that in the mini PCNL arm, bacteria were found in the majority of the spleen, liver, and blood cultures, compared to in the standard PCNL arms. And the concern, therefore, is that this may translate into patient outcomes. So in terms of mini PCNL with suction, here is a picture of the Poussin access catheter. And you can see that it comes as a one-step dilator, although you can also use smaller dilators prior to inserting the one-step sheath. It's connected to a suction bottle, and you have control for collection of the stone fragments. The suction's attached here, and you've got a lever here for control of the amount of suction, and here there's a finger port where you can close the port to increase the suction. I'm just showing a very simple illustration here. So you can see when the stone is fragmented, you get continuous suction of the debris, and then as you retract the scope, you can see that the larger fragments will collect into the bottle. The addition of suction may bring the advantages of reduced invasiveness of mini PCNL, whilst compensating for the disadvantages. Suction keeps the stone fragments close to the energy device, improving energy delivery and reducing fragment migration. It also aids the vision by continuously sucking out debris or blood, and it keeps the intrarenal pressure low and aids evacuation of the fragments. Here is an intraoperative video, and you can see that as the scope is retracted, some of the fragments will follow. Sometimes they need a little bit of a nudge to free them, but you can see how efficiently the fragments are evacuated, and you can see them leaving the port into the suction bottle just there. So what does the suction sheath add? Excuse me. In this single centre study below from the World Journal of Urology, they performed mini PCNL with and without suction. And in the mini arm and the standard arm, in some of the patients, they had a ureteric access catheter connected to a urodynamic machine so that they could monitor the intrarenal pressures. And they showed that the intrarenal pressure was kept below the threshold for pilovenous backflow throughout the operation in the arm with suction. With a mean cumulative time with the pressure above the threshold for pilovenous backflow at less than 30 seconds. And this was usually during the beginning when access was being attained before suction was connected. The meta-analyses and systematic analyses have shown that immediate and final stone-free rates are significantly higher in the vacuum-assisted PCNL. And they've also shown that shorter operative time, fewer axillary pressure procedures, and lower complication rate in the suction access group. So in real terms, how do we optimize the outcomes? Obviously, it'll be about case selection. Mini PCNL is ideal, where the stone is probably up to sort of 2.5 to 3 centimetres. The Hounsfield unit of the stone will matter depending on the energy device that you use. In terms of anatomical factors, it may offer advantages over standard PCNL, particularly in terms of narrow infundibula, and you get less collecting system trauma while manoeuvring around a narrow system. Mini PCNL is ideal where there are larger stones in multiple calyces that are less amenable for removal with a flexible scope. And you can get a flexible ureteroscope through the 16.5 French access sheath. Obviously, mini PCNL may be preferable in patients with a single functioning kidney or where blood loss is more critical. In terms of positioning, the supine position gives you a better sort of vortex effect, although this is ameliorated to a great degree with the suction access catheters. In terms of your available equipment, your choice of scope will depend on what you have available to you, whether you've got suction scopes available, whether you've got the mini access sheath, whether you've got the suction access sheath available to you. In terms of energy sources, the thulium laser does offer high efficiency with soft stones particularly, and there is some evidence to suggest that ultrasonic and the combined ultrasonic and impact devices may further add efficiency. In terms of available staff, obviously the surgeon experience is important, and there is a little bit of a learning curve, but not much to the use of the suction access in PCNL. Trying not to keep the system too collapsed so that you maintain your vision, obviously trying to keep your scope close enough to the stone to encourage it to move into the sheath, but trying not to rub against the mucosa, in which case the pressures can still build even with the suction. Obviously, if you want to perform ECRIS, then you'll need a skilled assistant. So in conclusion, optimizing outcome will be horses for courses. So picking the right procedure and the right access for each particular patient, being flexible in your approach. And as under urologists, it's always good to keep the kitchen sink on standby, using whatever we have available in our armamentarium.